asked Kim to keep this slide up because I wanted people to notice that my boat is completely flipped. But there's a story about that you will hear as I progress, because I don't think it was an act of intention, but sometimes these can still help us understand. Because in addition to the introduction, I'm a primary care doctor. I started my practice in general internal medicine and continued to practice primary care in internal medicine until 2009 in a private practice setting. I didn't join the university until about 7 years ago, and I did it because of that boat. That I was fully engaged in the challenges that we heard from Andrew earlier. I didn't get to the crazy doses, but I was seeing my patients fall apart. And I was being asked as I got older, I blame my loss of hair on my children, but actually it was probably pulling it out because I really cared a lot about my patients and I was making their condition worse. And the opportunity to join the University of Washington and make a change has been an invigorating experience. So I have no financial disclosures. You could read the objectives. I don't want to spend too much time on the objective. You can take a look. I hope I can hit these key topics: that how to access and evaluate your practice. So my focus is going to be, now that we heard the problem with opioids in this country, and Jay, great talk. You're still hired. I'm not going to fire you despite all the complaints about your heartlessness. But the opportunity to understand the emerging knowledge that we have about how pain systems work. And I'm going to link that to the CDC guidelines, a little quick run through, and our workshops will focus more on this, on how to put this stuff actually into your practice. How to take the biomedical and the psychosocial derived from the assessment that Dr. Ballantyne was talking about, the new model, and then how to get access to these guidelines. Because it sounds really, well, not easy, it sounds really complicated, actually, but it's even more daunting when you have heard what we've heard already and say, what the heck am I going to do in my practice on Monday when you get back to work? You got these patients, now you know all this stuff, and I got to tell you, it's hard when your boat's flipped. So this is the Lozier onion. Jane put it up, and I'm just going to, here's some definitions, a little more description on this. But I'm going to make a comment as a primary care doctor. I remember an old film from the 1975, Jonah, who'll be 25 in the year 2000, a very avant-garde French film at the time. And there were a bunch of guys cooking onions in the kitchen, and they were all weeping. These are these big burly farm men, and they're all crying from the onions. And as they cook the onions, the comment that struck me to this day, that when you first cut into the onion, it makes you weep, but the longer you cook it, the sweeter it gets. And the advantage of being a primary care provider is that you really have time with your patients, not in the visit, but you have the time to get the tears out and to recognize that, as my medical students say, what they learned after the rotation with me, the first thing is that these pain patients are really nice. Now, they say this in their fourth year, sometimes the last rotation. So despite our efforts in improving our curriculum, there's still this stigmata associated with taking care of patients with pain. We don't like it. Average is 6 to 8 hours in the United States. The veterinarian data is 84 hours of pain training. So there's a gigantic discrepancy, and if you don't know how to do it, you don't understand these concepts, there's no hope. Again, the courtesy of Dennis Turk on our faculty, it's a huge multidimensional burden. Jane was talking about the social connectedness of pain, the pathways of social isolation, which is what we do when we shove our patients out of the office as quickly as possible, or roll our eyes to our trainees. Oh, Mr. Smith. We teach those patients the hidden curriculum, and the patients themselves can sense this, because this sensitized nervous system that we learned about is also sensitized to social interactions. It's amazing. If I stifle a yawn because I was up all night on call and completely block it, I think, a patient without chronic pain doesn't even observe it. But a patient with pain always says, "Did you get enough rest last night?" They pick up on every little social cue, and this is the social isolation that makes it worse. So we as primary care providers have to be able to understand it, have to be able to connect to our patients and not be distressed. And frankly, the psychologists have the same problem. I know we have a good audience. The American Academy of Pain Medicine Psychology Shared Interest Group, the query was, why are there so few psychologists interested in chronic pain? Because it's a stigmatized disorder among psychologists. And their comments were, these are people we can't help. There's nothing to be done. And so the second lesson I learned from the medical students teach me is not only are they really nice, but there's something you can do. And that's my objective, that some of you will walk out today and be able to know how to handle it. So it was alluded to how important early childhood events are. This is great work by Rob Anda over the years. I'm sure you're all familiar with it. I took the liberty of adding chronic pain because this is such a dramatic incidence in the population of patients that we see in our clinic. We did a survey. It's at the Center for Pain Relief. We took a data-driven web-based tool that we do with assignments of patients when they come in, about 1,500 patients we looked at, and just anyone walking in the door, and 30% had PTSD. I mean, this is not a rare incidence. This is a driving factor. 55% had major depression, and 40% had generalized anxiety disorder. And if we don't begin to pay attention to those factors, and we treat existential suffering, which is what we're really seeing in many cases, with opioids and benzos, we're in the problem we have today. So how do we dig out of that? So first, I'm an internist. First thing is I want to be able to define what I'm treating, and that includes the treatment goals. So what am I treating? Am I treating acute pain, a symptom? We learned that opioids are fantastic. It's their excellent role. It mimics the endogenous opiate system as being in the off mode right away, and opiates will suppress that and do a major contribution to the relief of suffering that occurs in the acute and post-op setting. We expect things to heal, and therefore we're not going to be worrying about this condition going on for a long time. Chronic pain, granted, it's lots of different conditions. We can't lump them all into one, but if a patient has chronified for all those disorders, the goal is improved function. And I would add quality of life as well, and we'll dive into that a bit more because it's a very different goal than palliative care, end of life, cancer, pain, when the goal is comfort. So if we right away frame it, what am I treating? Am I treating acute process, or am I treating a chronic process? Or am I treating a palliative care? Really is a nice way for my younger trainees to understand. I think it's probably all obvious to this audience. And then you yourself, once you make the correct diagnosis, you can actually set realistic expectations for your patients. As I just actually learned last week at the American Pain Society, there's tremendous data now available with big data collections that Dr. Mack is doing at Stanford, that expectations seem to be in that diagram that Jane was showing for obesity. Expectations look like they're at the center of the action in terms of what our patients with chronic pain have. They need to have proper expectations, and if we promise them relief with opioids, that's their expectation set. I think we have to start in our own view of understanding what proper expectations are going to be, and that you can see expectations on outcomes need to be balanced with expectations of harm. And there's many opportunities to communicate that once you clearly understand that. And this gets to the shared medical decision making, which is a driving force in all our primary care practices. You have your patient involved in the discussion, and it takes time. It's not easy. We'll talk about some strategies during the workshops. And pursuing greater pain reduction via escalating opiate doses contributes to unrealistic expectations and clearly an iatrogenic injury, independent even of addiction, just in terms of the patient's function and quality of life as a result of our treatment. So I like going back in time. This is, here's our FACES scale. Thank you, Andrew, for introducing that. I want you to notice, this guy has his expectations set. They're all ready for him. But the most important thing here is this is medieval. And we're not medieval now, but yet we're still using pain intensity as our driving force when it's, as Dan Carr says, a social, psychological factor with some biomedical factors that we have to, and physicians especially need to get that diagnosis, the medical diagnosis, and approach it seriously not just blow it off, it's just chronic pain, because we can do a lot of things when we have a focal diagnosis. But when it boils down to a much more complicated problem, we have to measure it. I'm going to suggest, and this is actually recommended by the CDC guidelines, in fact, to use some more complicated, and it's not that complicated, a multidisciplinary assessment when you first see the patients. So this I credit Erin Krebs, primary care doc, women's health specialist. So this is in the primary care space. How do we learn about this in the exactly 6 minutes primary care providers have to evaluate and treat chronic pain? There's 7 other disease system states that you're typically managing as a family medicine or as a general internist. And then if you add on the electronic health record time and all the health prevention time, you have 0 time to even manage pain. So give an opiate prescription, we can get them out the door really quickly, but we want to collect this data. So pain intensity we ask, it's interesting question. What does it mean? We can have another conversation about that entirely, and Dr. Ballantyne and Dr. Sullivan also here can reinforce that. But it links to everything else because the patient uses the language of pain intensity to describe how wrecked their life is as a result of the burden of this pain and perhaps the burden of the life that Angus Deaton and his wife demonstrated, the existential suffering that's associated with that demographic group. Actually, undergraduate students are great. They teach us enormous insights. I asked the honors class, what does 12 over 10 pain mean when 10 is the worst imaginable? And it was a journalism student who said the most brilliant thing I've heard yet on that. It means the patient must be shouting. We give them numbers, and the top is 10, and they give us 12. That tells me I just better stop talking, telling them what to do. I just should sit there and listen. And some of the most effective patient outcomes that I have with the patient who's shouting is to spend the entire visit listening. I do nothing else, just listen. Very productive because you've developed treatment engagement. You can now make the next steps to introducing more broad concepts because they're shouting us with that high number. Enjoyment of life, general function. This is the PEG, P-E-G. Erin admits she also adds some impact on mood, and we'll talk about the specific tool. I would venture that PTSD probably ought to be part of your routine screening. We're putting it into some of our systems at UW right now. Pain interference with sleep, and then the treatment risks, particularly if you're considering opioids. So here's the PEG tool. It takes exactly, I've timed it, 7 seconds for your patient to fill this out. And that's usually the time it takes me to log on to my EHR. So you can get this done if they don't even do it in advance. 0 to 10, how much does it hurt? 0 to 10, how much does pain interfere with your enjoyment of life? So these numbers track directly with pain intensity, but as your patient improves, these get better. Pain is the last measure that moves. And we don't treat quality of life and function by giving opioids. They're the best way to stop quality of life. And there's plenty of data, we don't have time to go through it, that wonderful Danish study, an ecological study that showed the higher the opiate dose, the worse the function, and even more importantly, the worse the quality of life measure. And if our goal in chronic pain is to improve the quality of our patient's life, it's a chronic illness, just like diabetes, hypertension, cardiovascular disease. We don't cure those. Patient self-management helps, but the ultimate treatment is focused on having the best life in the face of this chronic disease. We use a PHQ-4, and we're going to work on this in the workshops and give you links to this. This is a combination of the PHQ-9 and the GAD-7. They add it up, you get extra points for how often this is a factor. This is validated 4-question screener. This takes 5 seconds. So right now we are still under 15 seconds to collect this data before we even start seeing our patient. And the PTSD questions, again, I've actually not timed it, but I would estimate based on the past number of questions, number of seconds, I think we can get under a minute. We can get all these key questions answered, and we can actually start to address the questions. So the way I language this to the patient, when these scores are all off the chart, I don't want to talk about you have to go see a psychologist. Sorry, Kevin, they're going to be scared away because they're going to think it's all in their head, and they don't want that answer from me. But it is in their head, as we learned. So I use a metaphor that has been extraordinarily effective because it's a biological basis. I simply say, I think your brain's on fire. And the answer I get with my highly distressed patients when they respond to me is, that's exactly how I feel. And they just open up. I now understand their pain scores can go down. I've asked pain intensity scores when they come in, 12 over 10. When they leave, I can get them down to 6 over 10 by just acknowledging that they are suffering, I'm listening, and I'm beginning to understand how they feel. Because pain is certainly a feeling that can't otherwise be communicated. This is some work originally by Fred Wolf. Dan Claus done a bunch of work on this too. This is another tool that we found useful. Some useful references for you. To make a diagnosis of fibromyalgia, you have to be up here on this score. Dan has other numbers on this, but we've introduced widespread pain as another important consideration, just to understand, particularly in the preoperative state. If you're going to recommend someone for knee surgery, total joint replacement on their knee, good data now supports from the University of Michigan group that if they're fibromyalgia-ness, it's a terrible word, but fibromyalgia-ness predicts poor pain outcome. The knee looks great. The orthopedic surgeon can't understand. Same applies for hips, and I venture to say we're beginning to look at that now for back surgeries as well. So these are patients who can fix the structural problem, the pathoanatomy, but if the pain system is in its full wound-up state, and pain is all over, and they have pain in the abdomen, bladder, chronic pelvic pain, interstitial cystitis, these are associated with poor outcomes. So setting expectations. Your knee is going to be great anatomically, but your pain is going to persist. May change the expectation setting. Many patients will still go ahead with surgery, but their expectations for how many opioids they're going to need post-operatively will certainly be reduced. We haven't proven that yet. We're working on that right now. So in 1995, I heard Muhammad Yunus speak when I was getting boarded in pain. And he introduced this idea, and it's been further advanced. I think it's the one image that if you walk away from, look at all the other things we primary care doctors see. Fibromyalgia, chronic fatigue, irritable bowel, tension headaches, headaches that the patients call migraine because they feel like that, but they're exacerbated tension headaches, TMD, myofascial pain, that's pain that just hurts all over. We can't understand the back sprain, and it's spread all over. Here's multiple chemical sensitivity disorder. It used to be formaldehyde and yeast. There's all sorts of explanations for that. It's a sensitized system that it can't even tolerate a smell. It's photophobia, phonophobia, foods and taste. These are the patients who have 12 different medication intolerances that make no sense. So if the patient has more medication intolerances than decades of life, begin to think of a centralized state. So this is the clinical tools that I would recommend using that will feed directly back into what Dr. Ballantyne was talking about. Interstitial cystitis and male pelvic pain, chronic prostatidynia is a centralized pain state. If you can't find and see the pathology, it's in the central nervous system. We saw that explicitly described earlier. There may be some peripheral nociception that's driving it, but you have to pay attention to that. And here again, PTSD. This is the pinwheel, the syndromic diagnosis. It's the positive review of system patient that we dread. But instead, widespread pain, total body diagram filled out. Every review of systems is positive. I astonish the trainees. I go, fantastic case, because I made the diagnosis. I know exactly what to do. Make the diagnosis. You can actually leap to the conclusions, and there may be, you still have to do your job, but this helps. Dan Claus has a great fibroguide.com. I'm just going to give you some useful things. This is the first treatment for fibromyalgia or any of the centralized states is exercise, sleep hygiene, behavioral health, CBT, ACT, other techniques as well, and self-management. This is a great guide. Patient walks them through. It's designed for your patients. First, on my after-visit summary, the first thing I do is I push. Unfortunately, I too am having to work with Epic, but you push the dot phrase, it pops up with the location and the rationale for this. And that takes a few seconds once you get it in your system. I'm paying attention to the 6-minute business because that's the reality of your practice.
Then non-drug multimodal analgesia. We'll learn a lot about the behavioral and cognitive, physical. Spiritual is, in my view, the ability to see things bigger than yourself and your own life. And that drives theological, it drives philosophical thinking. And this is why we have introduced a chaplain as part of our in-hospital rounds, not for palliative care, but for our general rounds with patients who've had trauma and are struggling and suffering without any meaning or purpose. If there's nothing else in that space but pain, it fills it. If you add meaning and purpose into that space, you can push the hopelessness and despair out of your patient's circumstance. And of course, education, because that sets the expectations. This is an example, and Dr. Ballantyne's working with our team at Harborview, which is our trauma center, all of WWAMI, Washington, Wyoming, Alaska, Montana, Idaho. So they see pretty broken people. This is real nociception. This isn't in their head. Yet, when we introduced medical nursing, can't do it without nursing, pharmacy, PT, OT, behavioral health, social work, chaplaincy, and addiction, when it gets assessed. So we assess addiction on the intake of these patients. So we can get this whole team together. It's tremendous. We're now studying the outcomes on that. And rubs and hugs, I think, could reduce your opiate dose inpatient by 50%. We're going to try to prove that. Dan Carr, the first treatment that any human being provides for someone in distress is that mother hugging the child. The next treatment is when you get an owie, you rub it. We still do it. It hurts. So I think that is a better and more effective way of managing, even in the acute setting, or at least minimizing opiate doses. What do we know about effectiveness? I'm going to do a little bit on drugs because we're living in that drug world. This is a comparing effectiveness, so there's never been head-to-head trials on any of these, so bear with me, those who are scientifically and academically inclined. But you can actually see opiates no more than 30% reduction. These are only really acute pain studies, so we see probably 1 or 2% improvement and up to 30% harm, which is what the problem is. But this is just short-term studies. Tricyclics, SNRIs, these drugs work in that rostral-ventral medulla picture. That's where the drug works. So the patients say, I don't want to be on a psychiatric drug because it's not in my head. I say, no, I'm treating your medulla and your brainstem. We're done. We got through it. They just don't want to be labeled in that circumstance. They work very, very well. Anticonvulsants, a little less effective in numbers needed to treat data, but also acupuncture. I'm not going to talk about cannabis because we're never going to get out of the room. CBT mindfulness training, great data. Actually, Dr. Turner in our group recently published that mindfulness seemed to have even more enduring benefits than the CBT program. And I'm waiting, this is a nice audience, over 200 people. Hand count. Anyone who's seen a patient die of an overdose of mindfulness? Okay, all right. Get my email address. I want to hear about it because it just doesn't happen. Instead, they get better. Exercise, and then sleep's a big deal. Good data in acute pain, over 50% reduction in pain intensity by just getting a good night's sleep. Another show of hands. How many has ever seen a patient with chronic pain who's sleeping? Okay, I've never seen one either in 30 years. And so I treat sleep first. Very palpable. We're not going to talk about pain. We're going to get you sleeping. They say, great. They come in sleeping better. I set the expectation. They come in sleeping better. They start to feel better. And everything can start to flow. So I think sleep is probably the best first target. But you can't target it. If you ask the patient, how are you sleeping? They can say, well, it's my pain doc. I'd sleep better if I didn't have any pain. I can say, no, as your sleep improves, your pain will improve. And that's the number one priority. And that's a first pathway to go. We saw this earlier. This is the Pathways to Prevention workshop. Evidence is insufficient to determine the effectiveness of long-term opiate therapy for improving chronic pain and function. Actually, the evidence supports a reduction in function and quality of life, as I've alluded to already. If we're dosing opioids, big controversy of what the dose limits might be. I'm doing a quick step for the sake of time now. But the numbers that you're seeing now are between 50 and 90, and this is based on this sequence of curves. Dr. Von Korff, who's visiting us with, was involved in the Dunn study at Group Health Hospital. This was a well-insured population, nice neighborhood in Seattle. They just looked at people on prescription opiate overdoses. And there was a 9-fold increased risk when you got over 100. We first proposed 120 MED as a dose limit. You're seeing those numbers. We made that number up. As Dr. Glass, who's here, knows, we looked at the population that would be necessary for these people to be evaluated, and it was in the tens of thousands. With our original number, I proposed 80 at the time. I got it kind of right by just watching my own practice. But there was just tens of thousands. So we kept dialing the dose up until we could have a manageable group of patients, because we were expecting them to see a consultant, and there was exactly 0 specialists available to see patients. They were there, but all the practices were closed. Their number were listed, but they had been run out of the state already, thanks to Department of Justice activities, because they were running pill mills. And the others were fully closed. So we had a big problem. We came up with that dose. Now it's subsequently been validated. So I consider, when I teach my medical students, residents and fellows, a 50 MED is where you're going to get in this deflection, where you're actually going to see adverse, and this is just straight overdoses. This isn't dealing with addiction complications, falls, hypogonadism, cortisol depletion, all the other things that make people feel miserable. You want to make someone feel bad? Reduce their circulating hormones, testosterone and estrogen. If anyone's, my wife will tell you, it is not a good thing to have your estrogens dropped. And men who are made hypogonadism by opiates have hyperalgesia just from the hypogonadism. Hypertestosterone will reduce energy, fatigue, concentration, produce pain. So we're just making the problem substantially worse. This calculator, it's referenced in the Oregon guidelines. It includes a whole bunch of drugs. This is what it looks like. Requirement number 1, if you're going to be prescribing opiates, you have this downloaded in your device, whatever one you have, or on your laptop. First question, what's the MED? Because you got to know what the MED is so you know the risk. And the drugs are complicated, and we'll be talking in one of the workshops, Melissa later tomorrow, we'll be talking about knowing this. You got to know this if you're prescribing the opiates, what is the potency of these drugs. And you really have to know methadone, because methadone inhibits its own metabolism. It's the only drug that does that. So the more you give, the more potent it becomes, but not in a linear fashion, but in a curvy linear fashion. So as you increase the dose from 20, it's a 4-fold multiplier, to above 80, a 12-fold multiplier. There's no other drug that does that, and that's why methadone leads the death rate for opiate-associated addictions. And a big change I understood in this state occurred when methadone was taken off first-line formulary. It should stay off first-line formulary, but it's a reasonable drug for patients for whom it's appropriate for pain, and certainly an appropriate drug for medication-assisted treatment. But just be aware of the unique lethality of methadone, and it's basically pharmacology. And I'm sure I didn't know it because I had some bad outcomes with patients on methadone, including accidental overdose deaths. And that's me in the boat flipping over. I can tell anecdotes that will take too much time about how much that affects you. When you do this and your patient dies, you say, I'm not reading the books right, or it's not in the books yet, and it isn't. So this is all new. We're in a paradigm shift right now. We're now right over the top. But we get it, as we heard, is now we don't have to be taught about it. But now that we're over the top, we still have to know what the tools that we've been using historically and how remarkably potent they are. Lots of controversy, even over our dinner last night, about whether this opiate risk tool is useful. We find it useful because it gets a family history, a personal history of substance abuse family history. The age, as we know, maybe should be adjusted based on Dr. Kalani's presented data. Here's the PTSD surrogate, pre-adolescent sexual abuse. They make a mistake. Men get it just as bad as women, but I didn't make the tool. And then the impact of psychological disease. And this just tells me this is a patient I have to be really on guard for. This doesn't diagnose addiction. It doesn't predict addiction. It suggests this is a patient's going to have trouble controlling opiates according to the recommended treatment plans that you offer. Another interesting phenomenon, and it's again called out in the CDC guidelines, be highly alert to sleep apnea. And this is Walker's study that I've not seen one better yet, from 2007. So you look at this and you say, well, as you increase the MED, this is why you need to know the MED to understand this. As you increase the MED, you are going to have a higher incidence of sleep-disordered breathing. But this, if you look carefully, this isn't obstructive sleep apnea. That's central sleep apnea, for which we have no treatment except eliminating the offending condition, which is opioids and benzos. So the problem resides in this. CPAP isn't going to treat central sleep apnea. And that's why they die in their sleep. That's why their sleep is terrible, and they feel fatigued, and their pain is worse. So here we go back in that vicious cycle to recognize why our patients are doing so poorly on these drugs as we begin to accumulate new data. Speaking of benzos, we're not doing so bad in the Northwest. This is opiate pain relief. Here's the benzo overlap. For some reason, our cascades soothe better than your cascades, but they don't need benzos quite as much in Washington State. So if this is, again, one of those color maps. This is extended release, long-acting drug prevalence, and this is at dose. So there's still some work we need to do in the Pacific Northwest, no doubt, but this is combination of opiates and benzos called out as a dangerous combination, and it's because of the risk of not breathing. Bad thing. Unless you're in the operating room, being given opiates and benzos as the general anesthetic. That's the general anesthetic. The difference is, and the doses they use are quite high, of course, difference is you have an anesthesiologist attending you. You're intubated, you're on ventilation, and all your vital signs are being monitored. So we're giving anesthetic doses of drugs in the outpatient setting. Not a good idea, I don't think. In Washington State, you're probably familiar by now, this was became a law with nickname 2876. This basically excludes acute pain, surgical pain, palliative care, cancer pain. So this is chronic, non-cancer pain. Get your education and guidelines. Access specialists when things are not going well. Focus, first call out pain, function, mood, risk. That pain may be one of the important things, but function, mood, and risk is critical. And then you have to track opiate adherence. This seems like common practice. This had to become a law in Washington State because the original guidelines were reviewed by less than half the providers of opioids. And actually, it was family medicine people only responded to the survey. No one else did. Less than 50% even were aware of that. 20% had read them, and no one had changed their practice as a result of the original guidelines. So it took a law, unfortunately. I think a profession means that they self-manage their own profession and set their own rules and regulations. And when the profession fails, as we learned from Andrew, regulators come in and government comes in. And I think it was the right thing to do because we've had good results as a result of that. But you don't have a law yet. So this kind of work, Jim, everyone in the room who's put this together, is going to make the profession a profession again, and not a bunch of cowboys without data getting out of the exam room as quickly as possible. So our data, and I failed to get the update, this is our first guideline introduction. So we did have an effect, even though our studies show that it wasn't. This is 2007 when our first guidelines were introduced. This is the rulemaking, and our current data in Washington State's a bit over 40% reduction in prescription opiate overdose deaths. So you get results by making this happen. Unfortunately, we've learned, and it was, Andrew, that was a great discussion of why it isn't just driven by the reduction in opioids, but we had the opiate, this is from Washington State, Caleb Anna Green's work, prescription opiate overdose, total opiate deaths, so that even the total has gone down, but we have seen this bump, and it times very nicely, Andrew, with the data that you were showing. It's more than just restricting opioids, although the opiate prescribing in the state has clearly gone down. 2009, we were seeing patients with 4 grams MED coming in regularly. Now our trainees say this patient's on such a high opiate dose. The MED is 140. And I smile because it's good. 140 is a dangerous dose, but it's at least a dose that we can get our hands around and make some progress. So it isn't all hopeless. Here's your guidelines. They're really great, and I got to say this collaboration between Washington State and the state of Oregon is phenomenal. It's been productive. I love coming to this area. I'm going to see Shakespeare tomorrow night. I'm thinking about it all week. But the group here, and I just want to say out of everyone, boy, girl, man, woman, everyone involved in this whole process, because this is how you make the change. And I tried to be an artist here. We're going to shake hands on moving forward in this. This is the CDC guideline. I'm going to spend a few minutes. Huge topic. We're going to start a webinar series. UW was just selected, fortunately because of all the work we've been doing and our leadership in the development of these guidelines, to be the disseminator of education to teach primary care people how to do this. Because when a guideline comes out with recommendations, if you're on the front line, this is a rule. You have a bad outcome, disciplinary boards, you're in trouble. So the pushback from primary care is not that the guidelines are wrong, because they're all completely reasonable, and we'll walk through them quickly. It's because, how can I do this? And if I don't do this, I'm going to be in trouble. So the challenge that we have now is to get everyone trained on best practice pain medicine, how to get off the opioids, and you're going to have tapering workshops. We're going to talk about all sorts of specific practices tomorrow and how you can accomplish this. But they've broken it down, and my numbering got lost in translation. When to initiate or continue opiates, selecting dose, titration, duration, and follow-up, and then risk and addressing harms. 3 main themes in that. Quick flyby, I've highlighted the key points. I think the color comes out. This is in the initiation. Non-drug therapy, this is recommendation number 1. Non-drug therapy starts your treatment of chronic pain. That's the first goal. No overdoses on non-drug therapy. Then non-opioid pharmacological therapy, when it's necessary, are preferred for chronic pain. And I've excerpted these. These are the sound bites that come out of the guidelines. When you read the recommendations, you're going to say, what? Where'd they come up with it? There's a huge, detailed, thoughtful, evidence-based literature review that supports each one of these. So just reading the sound bites, that's what we hear in politics of the sound bites. We can do better. I would really recommend reading through the document systematically, seeing what's supporting that, so you can understand pain. Dr. Ballantyne made a great effort this morning earlier with. And if you understand pain, your patients improve. Some work done in Australia by Laura Mosley, physical therapist. He's done some work. I have not seen it published. Maybe someone has seen that. They did an assessment of knowledge of pain by providers of pain care, and then followed the outcomes of their patients. And if the provider passed the exam of understanding pain, the patients had over 50% improvement in their outcomes. So we got to understand it first. And because we weren't trained, is a problem, but time to move forward. We're getting trained, and thanks everyone for coming here and inviting me to help that process. We just went through this. Before starting opiate therapy, set realistic goals for pain and function. Call out, that's our treatment goal. You can't not talk about pain. You can. When you have these tools, you can talk about sleep, you can talk about mood, you can talk about quality of life. You don't ever have to mention the word pain in the discussion. You can say, it looks like your brain's on fire. That addresses that some, but you're going to need to talk about function. And before starting therapy, discuss with the patient the risks and realistic benefits and their responsibilities for managing. This is the treatment agreement. There's nothing new or fancy about this. They also recommend naloxone, which we are now doing regularly. It's one of the guidelines we're going to talk about later, one of the recommendations. Because when you give your patient who's got sleep apnea, all sorts of medical diseases, on benzos and opioids, if you also say, this is so dangerous, I'm going to ask your family member to come in the room and teach them how to use naloxone to rescue you from an overdose death, it sort of changes the conversation a little bit, that you really mean it. Now, they may not fill it, but just writing that prescription, I've been doing this for a while, but I'm now doing every visit. And I got to say, the EHR actually has a naloxone recommendation for self-administered, for family-administered naloxone. Suddenly the patient says, you know what, I don't think I want to do this anymore. And certainly the family member is less enthusiastic and won't be whining for more opiates to help their spouses or significant others suffering. What's up here? I lost control of my moving forward. All right. Opiate selection dosage. Again, when starting opiate therapy, this is something the University of Washington promoted back in the 70s and 80s. If a patient's taking lots of short-acting opiates, you must put them on extended-release long-acting opiates. They made it up. It seemed like a good idea because, I take a pain medicine, it's good operant conditioning, and to disconnect the pills. You want a nice stable dose. Well, there's no data, zero data that it supports it. And I know work that Dr. Sullivan's done and may speak to a little later is that what gets you in trouble are the extended-release long-acting opiates. Because if you wrote a prescription, how many here feels comfortable with a 30 or 60 for a month's supply of a medicine. All right, that's not so bad. We're used to those numbers. How many here feel comfortable with 600 or 800 per month of a prescription? You just can't do that, but OxyContin can do that. 80 milligrams 3 times a day, which is not an uncommon prescription. You have to write over 300 to 400 pills a month to be able to accomplish that. And you know something's wrong. And the patient knows something wrong. They say, I'm sure you've all heard it, I'm taking so many pills I can't even eat. And when the patient's telling you that, you have a problem in your practice. So they got us out of that conundrum of not being able to write crazy numbers of pills on our dispense rate. But using the immediate release works. You get them off. There's no hardship with that, and tapering them, and we'll be talking about that later. Off the extended release turns out to be more of a challenge because of the decrements. And insurance regulations about getting it filled. So start, and probably rare circumstance for chronic non-cancer pain that you'd ever use one. I've just gotten it out of my practice. There's some rationale in a subset of patients, but it doesn't make any sense. And then here's this most contentious number. Greater than 50, you should avoid. Between 50 and 90. We have data now. We got slaughtered in 2007 when we presented this because we had no data. We only had the data. We assembled the experience in treating pain. We had 350 years of experience in the room when we came up with that data. Now that's clinical judgment, but we were reinforced by the fact that that is the problem dose range when you end up with all sorts of stuff. There's certainly no safe dose. A single exposure to opiates in youth may trigger a long-term addiction problem. These are big concept challenges that we still face, but really this is the number you should be at, and you will be able to dodge multiple bullets. And this is still not working. Magically, it hasn't fixed itself. Okay, opiate selection, dosage, duration follow-up. Use the lowest effective dose of immediate release and no greater than needed, and this is the 3 days or less will be sufficient, because in the primary care setting, people come in your office with an acute traumatic injury, and opiate's appropriate. 3 days is reasonable, maybe 7. If it's post-operative and it's a seriously complex surgery, this is a lot of pushback. This does not apply. If you read more than the soundbite, you will see that they refer you to the Washington State guidelines, which talk about post-operative dosing recommendations, and we suggest 2 weeks. 2 weeks, because if they leave the hospital and 2 weeks later they're still needing a lot of opioids, it's time to take a look at that patient. There may be a surgical complication. There may be diffusion to the community complication of that drug. There's lots of reasons that I may need to pay my copay with the street value of these drugs. So you've got to get that patient back in again in 2 weeks, regardless. Evaluate benefits and harms early, and if benefits do not outweigh harms, taper or discontinue. Now, is this a tough concept? Can anyone argue that this is the right thing? If it's making your patient worse and they're not improving, you get them off the drug. I don't think there's any other drug in the business of healthcare where if we don't see improvement or any value to it, and there's harms, that we would ever consider continuing it. We don't have to spend much time on it, but that's the way. If you really believe that and understand that truly, it'll change your ability to language this truly with your patients. Risk of harms of opiate use before starting and periodically during continuation. This is for chronic opiate therapy. Different states have different regulatory. First dose, do you have to go through the office of spraying? You're giving 5 pills, 8 pills of a drug. Do we need to assess that risk? One could argue maybe not. They don't require that, but consider that on chronic therapy. Chronic therapy is 90 days, because this neuroplasticity event that was beautifully described by Dr. Ballantyne really is in 90 days. Everyone is going to have this neuroplastic change that's going to transfer the benefit and the quantification process taking place. Consider offering naloxone, as I alluded to. And the naloxone recommendations are if the patients have a history of overdose. Annals of Internal Medicine recently published that if looking at patients who have had a documented opiate overdose event, what's the likelihood that they will be continued on that same dose when they go back to the primary care office? It's over 90%. What? it just can't, it's just astonishing. And actually about 10 or 15%, I haven't read the article recently, 10 or 15% actually had their dose increased. So this is, again, one of those no-brainers that if your patient had an overdose, this is a serious event. Whether they should be on opiates at all, should be on buprenorphine at all, is there an indication for chronic opiates? Have they been benefited? This gets us into this tumble of reassessment. So overdose, history of substance use disorder, high opiate dosage. What's high? Is it 50? Is it 90? I would propose 90 would be your naloxone threshold. We don't know that. We're doing some work on that now, but it's pretty preliminary. Or concurrent benzos. And that's a good conversation. You're on benzos and opiates. Your dose is not high, but this could kill you. You need the naloxone. Again, sense the patient and the family that there's some education. Talking is great. Walking is even more potent. So you're doing the walk now. You're giving them that particular prescription. Review the PDMP data when starting opiate therapy for chronic pain and periodically during opiate therapy for chronic pain. It's phenomenal. The experience that I had with my old practice when I brought him over to the University of Washington Clinic, I remember telling one patient in particular, I said, this guy, I've known him for 20 years. He's absolutely a straight shooter. We don't have to worry. And his urines were all matched. I ran all my patients through the PDMP, and about 25% of them were double dipping. If I'm not humbled every day, I'm not doing my job. And I got to tell you, it was humbling. The PDMP is so useful. And it takes a couple of clicks, and we got to get it into your EHR, and you could delegate it. We can talk about that more in particular, but it is a remarkable tool. Check urines. Avoid prescribing opiates with benzos whenever possible. And most importantly, and speaking to what Dr. Kolodny was speaking about earlier, offer or arrange treatment with buprenorphine or methadone when the patient has a diagnosis of an opiate use disorder. So don't pretend it isn't there. You can tell there's a problem. You see these aberrancies. You know this isn't going well. Get the addiction help if you don't have it yourself. And how many people are buprenorphine trained you have? Oh, excellent. Nice job. Washington State's only 23%, and less than 10% of them actually use it. So we have a big problem with getting people to use buprenorphine, and that's a whole separate discussion. So if not opioids, what then? Lots. Patient education, non-drug multimodal analgesia, non-opiate drug multimodal analgesia. These are all the terms that you hear. Lots, acetaminophen, NSAIDs when appropriate, tricyclic, cyclophosphamide, anticonvulsant drugs, et cetera, if you're going to be using medication management to support. For the sake of time, I'm just going to leave this up here while I focus on the key point. Make the diagnosis of what the pain, acute, chronic, palliative, and then what type. Is this nociceptive pain? Rest, ice, acetaminophen, and NSAIDs, very reasonable for acute pain. Neuropathic pain, a different subset of drugs that are non-opiates that are very useful. The central sensitization syndrome, they're really easy. TCAs or SNRIs, anticonvulsants, exercise, and a behavioral intervention. 4 things, every one of those patients. Very easy. I know primary care docs take care of a lot harder things than managing chronic pain, and the reason is you've never been taught how to do it. How are you supposed to know when you've never been taught? The problem is getting access to some of these treatments. Depression and anxiety, make the diagnosis and treat it. Don't treat depression with benzos and opioids or anxiety or PTSD. PTSD, we use a lot of prazosin. We can talk about that in the workshop, how useful that is. Fantastic drug. Again, behavioral therapies. An opiate use disorder, when you make the diagnosis, they go on methadone or bup. That's it, off opiates, and you're not going to go down the path of treating that. So why bother? The last 2 slides. 70% of primary care visits include pain complaints. 30% of your practice has chronic pain, not all of them on opioids. Up 98% of chronic pain is managed by PCPs or emergency departments. Most of the opiates are prescribed by us, primary care folks. Between 18 and 32% of chronic opiate therapy patients in practices meet addiction criteria. We heard that earlier. Primary care providers are the core of the medical home, so this business has to be in your medical home. You need to know how to do it because that's where the action is. And you've got just 6 minutes. That's the daunting. So you can stack your visits, put 2 15-minute visits together and bill for time. I have a phrase, dot time, and I got the whole phrase listed, and it's counseling, coordination of care, describe what you said. And you can do a 30-minute visit, and people say, I can't do it in 15. Say, well, do it in 30. And a patient who's in big trouble, do a 45. You can bill for time up to an hour, and it may not be happy for the numbers coming through your clinic, but it will surely improve your outcomes. So first steps, and we'll talk about more, and this is in conclusion, to enable your practice, evaluate your practice. We're doing some work with Group Health. Dr. Bronkhorst is part of the study on team-based opiate prescribing. So we're asking the clinics to take a look at their own practice systems. Do you have an opiate registry? Is there a standard meeting of these patients who are a problem? What's the process for putting patients in this system? A consistent policy for urine drug testing and PDMP for every patient on chronic opiates. How often you do it, what's the workflow, whatever works, but you have to have it. Accessible outcomes tracking, you gotta have these tools to make the diagnosis. Evidence-based guidelines, can you click right away? Can you reach into a drawer and pull these out if you don't know how they work? Everyone should be buprenorphine licensed, at least a significant portion of a practice if you're prescribing opiates. A performance review cycle in your practice so you can see is it working, and then determine your own clinic's implementation strategy to implementation of the best practices. Quick and easy. Harm prevention and guideline and rule adherence. Are you following the rules? And the quick, easy wins might be registry of patients who are on opioids. Make sure everyone has a specific pain diagnosis, stratified by morphine equivalent dose. Opiates and benzos, that's a quick EMR check to see if the patients are on that. Check for sleep apnea, et cetera. So in Oregon, just do it, the Nike swoop, because you can do this Monday. You could sit down and begin to develop this process right away. This isn't something that's going to take a huge amount of time. So when you're stuck, you can use, I see one of our audience, Catherine, who regularly attends our telemedicine. This is teaching how to do this. Present your case. We will be able to handle. We have a multidisciplinary group, including Dr. Ballantyne, Dr. Sullivan, myself, and others, to teach you when you get stuck and get you out of trouble. This is a link to a toolkit. Everything I just said is on this toolkit. You can just go. It's open access to anyone. All the guide, all the tools, you can download them, get as PDFs, and you could put copies of them, and by Monday at noon, you can have every one of your patients doing this. We're going to have questions, I understand, at the end of the full session, so I appreciate your time. Thanks very much. I look forward to seeing you in the workshop.